Imagine a newborn patient is wheeled into your clinic. You look at their arm, and they have absolutely no thumb.
Oh, wow.
Yeah. Instead, they have 7 fingers perfectly mirrored down the midline, supported by 2 ulnae in the forearm, and 0 trace of a radius. I mean, how does a reconstructive surgeon even begin to build a functional hand from a statistical unicorn like that?
Honestly, it is one of the most daunting architectural puzzles in all of surgery.
It really is. So today we are mastering the clinical classifications and the surgical management of polydactyly.
Right.
If you are a resident preparing for board exams, like the FRCS in plastic surgery, this revision deep dive is built exactly for you. But before we start unpacking the surgical algorithms, make sure you hit the follow button wherever you're listening so you never miss these revision sessions. And please rate the show if you find today's breakdown helpful.
And remember to grab a premium subscription to access our dedicated journal club and clinical cases deep dives.
Highly recommend those.
Yeah, those premium sessions are strictly focused on taking these high-yield facts and, applying them to complex clinical scenarios.
Get that premium subscription for the clinical cases. You won't regret it. All right, no time wasted today. We are doing a rapid-fire question and explanation session.
Sounds good.
So for the sake of the examiners, we define polydactyly strictly as having more than 5 digits on a hand. It's one of the most common upper limb malformations you'll see.
Absolutely.
And in the exam, the moment you see an extra digit, your brain needs to immediately split the algorithm. So let's start with the ulnar border. Post-axial polydactyly. What are the key epidemiological differences between patient populations that board examiners absolutely love to test?
Yeah, so the demographic split is the very first trap in the exam. Ulnar polydactyly is generally an autosomal dominant trait with variable penetrance.
Okay.
But the incidence, and more importantly, the clinical implications, vary wildly based on who is sitting in front of you. So in African-American populations, the incidence is about 1 in 150. It's a relatively common, usually isolated and, benign finding. But in Caucasian populations, the incidence drops off a cliff to about 1 in 2,000.
Wait, really? So in one demographic, it's basically a routine clinic visit, but in the other, it's incredibly rare.
Exactly. And that rarity in Caucasians is your massive clinical red flag.
Because of syndromes.
Yes, precisely. When ulnar polydactyly presents in a Caucasian patient, it's very frequently associated with other underlying syndromes. The examiners want to see that you don't just, stare at the hand.
Right, you have to look at the whole picture.
A strict, thorough search for other systemic abnormalities is absolutely mandated. You have to evaluate the entire patient.
Makes sense.
And furthermore, just as a general baseline rule for post-axial duplications, it's often bilateral, and it presents more commonly in boys.
Okay, so 1 in 150 for African Americans, mostly benign. 1 in 2,000 for Caucasians, which mandates a full syndromic workup.
Yeah.
Mostly boys, often bilateral. That is a perfect algorithmic branch point for your revision.
Yeah.
So let's talk about the anatomy itself.
Yeah.
Walk us through the Stelling classification for ulnar polydactyly.
Sure. So the Stelling classification basically breaks down the structural integrity of that extra ulnar digit into 3 types.
Okay.
Type I is a soft tissue mass only. There's no skeletal structure, no bone, and no cartilage inside.
Just floppy tissue.
Right. Then type 2 is a digit that contains all the normal structural components, and it articulates with either a normal or a bifid metacarpal or phalanx.
Got it.
And finally, type 3 is a complete, fully formed extra digit with its own dedicated metacarpal.
Okay, let me push back on the surgical management here, specifically for a Stelling type I.
Sure.
If I am looking at a patient with just a floppy soft tissue mass on the ulnar border with absolutely no bone inside,
Yeah.
why can't I just tie off that stock with a simple suture ligature right there in the clinic? I mean, you see that technique mentioned all the time in older literature.
You do see it historically, yeah, but bringing that up in a modern board exam is a fatal error.
Really?
Yeah.
Why is it so bad?
If you use a simple ligature to tie off the blood supply, you are essentially performing a slow, uncontrolled traumatic amputation.
Ouch.
Yeah. And the biological problem is that it frequently leaves a residual nubbin of tissue.
Oh, because the skin just heals over whatever, like microscopic cartilage or nerve endings were at the base of the stalk.
Precisely. You leave behind this hard, painful neuroma or a cosmetically unacceptable bump that the parents will inevitably come back and complain about.
Right. Not ideal.
Not at all. Instead, the gold standard is that a type I mass must be formally excised under local anesthetic within the first few weeks of life.
So you actually open it up.
Yes, you dissect out the tiny digital nerves, cut them cleanly so they retract deeply, and then close the skin for a smooth contour. That completely avoids the residual nubbin complication.
Got it. So absolutely no tying off soft tissue masses in the clinic. Formal excision under local is the standard. Let's move to the heavier reconstructions for stelling types 2 and 3.
Okay.
We are taking off a bony digit now. What is the biomechanical trap here?
Well, for tops 2 and 3, you perform a formal surgical excision of the extra digit, but the trap is the soft tissue reconstruction. You can't just amputate the extra pinky and close the skin.
Why not?
The high-yield surgical pearl here involves the stabilizing anatomy. You must meticulously transfer the attachments of the ulnar collateral ligament, the UCL, and the abductor digiti minimi, the ADM, from the amputated digit over to the adjacent retained finger.
Right, because if you just amputate that outermost extra digit, you have essentially cut the guy wires holding the adjacent pinky up.
Exactly. You are removing the lateral support.
So you have to take those guy wires, the UCL and the ADM, and securely anchor them to the remaining digit so the pinky doesn't collapse or drift outwards under the mechanical pressure of a normal grip.
That is the exact biomechanical mechanism. You are restoring the functional architecture, not just throwing away the extra parts.
Beautiful. Now, we've fixed the perimeter, but as we move from the ulnar border to the center of the hand, the architecture gets hopelessly entangled.
It really does.
Let's look at central polydactyly, which is the absolute rarest form of duplication. Which digit are we usually dealing with here, and what is the structural nightmare waiting for the surgeon?
So central polydactyly almost always affects the ring finger. That's your quick multiple choice trivia.
Ring finger, okay.
But the structural nightmare is synpolydactyly. We just talked about stelling type 2, where the extra digit articulates with a normal or bifid bone.
Right.
Well, in the central hand, a stelling type 2 variant usually occurs concurrently with syndactyly, meaning the duplicated digits are entirely fused together within a single skin envelope.
Wow, so you have a duplicated skeletal structure hidden inside web fingers. How do you possibly choose what to cut? I mean, they are essentially sharing a biological highway right down the middle of the hand.
It is genuinely one of the most difficult mandates in pediatric hand surgery.
I can imagine.
For central types I and 3, it's a relatively straightforward excision and reconstruction. But for type 2 synpolydactyly, those fused digits are just a tangled web.
Everything's mixed together.
Yes. They might share flexor tendons that bifurcate abnormally. They may share a digital nerve that splits exactly where you want to make your incision. And they often rely on a single shared blood vessel.
So you can't just slice a scalpel down the middle and hope for the best.
You absolutely cannot do that. The surgical requirement is to meticulously dissect the entire complex, identify every single tendon, nerve, and vessel, and then intelligently select the most robust skeletal and tendinous elements from that combined mass.
So you're basically building a custom finger.
Exactly. You are discarding the weak elements and combining the best parts to construct one single optimal functional digit.
You are looking at the blueprint mid-surgery and cherry-picking the best biological hardware.
That's a great way to put it. It requires flawless preoperative imaging and incredibly adaptive intraoperative decision-making.
All right, let's transition from the tangled center of the hand to the absolute cornerstone of hand function, the radial border.
The thumb.
Pre-axial polydactyly, specifically the duplication of the thumb. This is an area heavy with classification systems and highly testable reconstructive principles.
It really is a favorite for examiners.
First, the demographics here flip completely from what we saw on the ulnar side. Radial polydactyly affects Caucasian populations more than African American populations. It's usually unilateral, and it's largely sporadic. Syndromes are quite rare here. But if a syndrome is present with a duplicated thumb, what specific life-threatening condition must you screen the child for?
Fanconi's anemia. That is a non-negotiable, must-know fact for the boards.
Fanconi's, okay.
Yeah, if you see radial polydactyly alongside syndromic features, you must initiate a screen for Fanconi's anemia.
Syndromic duplicated thumb equals Fanconi's anemia screen. Locked in. Aside from that, what should we know about the baseline physical anatomy of these extra thumbs?
The overarching rule is that neither of the duplicated thumbs is perfectly normal.
Neither of them.
Neither. Both typically demonstrate some degree of hypoplasia, meaning they're undersized or underdeveloped. Furthermore, while the neurovascular anatomy is highly variable, The most common scenario is that there's only one dominant vessel supplying each duplicate.
So we are dealing with two underdeveloped digits, each hanging on by a delicate, solitary blood supply.
Exactly.
Let's get into the heavy-hitting classifications. The examiners love the Wassel classification for radial polydactyly. But please, do not just give me a rote list of 7 types. We need a conceptual framework so residents can actually remember this under exam pressure.
Okay, the best way to visualize the Wassel classification is to think of a zipper unzipping the thumb, starting from the very tip of the nail and moving proximally down toward the wrist.
Oh, I like that.
As the zipper moves lower, the classification number gets higher.
Okay, walk us down the zipper. Type I.
Type I means the zipper only caught the very tip. It's a bifid distal phalanx representing about 2% of cases.
Barely unzipped. Type 2.
Type 2 unzips a little further. It's a completely duplicated distal phalanx, which is about 15%.
Okay, type 3.
Type 3 unzips past that first joint. So you have a bifid proximal phalanx with a duplicated distal phalanx. That makes up 6%.
And here's where the zipper gets stuck most often, right?
Yeah.
Type 4.
Exactly. Type 4. This is where the zipper has moved past the first 2 joints, resulting in a completely duplicated proximal and distal phalanx.
Both bones duplicated.
Yes, and this accounts for a massive 43% of all cases. Type 4 is the absolute most common type, and it's guaranteed to show up on your multiple choice exams.
So type 4, the zipper is stuck at the metacarpophalangeal joint. Duplicated proximal and distal phalanges. 43%. Let's finish the unzipping.
All right, type V continues down. It's a bifid metacarpal with duplicated proximal and distal phalanges sitting at 10%.
Okay.
Type 6 means the zipper has gone all the way into the hand. You have a completely duplicated metacarpal along with the proximal and distal phalanges. That's 4%.
And the last one.
Finally, type 7 breaks the zipper rule slightly. Type 7 is a triphalangeal thumb. So a thumb with 3 bones instead of 2, accompanied by a normal thumb. This one is surprisingly common, making up 20% of cases.
So type 4 is the undisputed king at 43%, and type 7 is the runner-up at 20%.
You got it.
Let's connect this anatomical blueprint to the actual surgical execution. The goal is a well-aligned thumb with stable joints, balanced motor functions, and an aesthetically acceptable nail plate. When exactly are we operating, and how does a reconstructive surgeon decide which of these 2 thumbs to keep?
The timing of the operation is absolutely critical. Surgery is typically performed at 1 year of age.
Wait, why specifically at 1 year? Why not at 3 months or, 3 years?
Because of the brain, you intentionally time the surgery prior to the child's development of the thumb index pinch.
Oh, fascinating.
Yeah, you want the newly reconstructed thumb healed and mechanically stable before the brain's motor cortex starts hardwiring that specific pinch reflex.
Because if you wait too long.
If you wait too long, the brain learns to use the deformed anatomy, and post-operative rehabilitation becomes significantly harder.
That is a brilliant physiological constraint. Now, how do we choose the survivor?
You have to evaluate a matrix of factors. Size is the most obvious. Often one duplicate is just rudimentary. Interestingly, the radial-sided duplicate is usually positioned more proximally and is smaller, so the ulnar-sided duplicate is the one that's most frequently kept.
Ulnar survives. Got it.
But you also evaluate angular deviation. You look at shared function. I mean, it's entirely possible to have the flexor tendon pulling on one duplicate, while the extensor tendon only works on the other.
So the motor functions are literally split between the 2 thumbs. That's wild.
Yes, which makes the reconstruction incredibly complex. You also assess passive mobility of the joints, and you rely heavily on preoperative radiological appearances to ensure you aren't missing, like, a hidden triphalangeal element.
Right. Let's break down the actual surgical mechanics.
Yeah.
Walk us through the step-by-step principles for the classic removing one and reconstructing the other approach. We typically use this for Wassel types 3 and 4, or if we have highly asymmetric types I and 2.
Right. Exactly. The standard sequence begins with amputating the smaller, usually radial duplicate.
Okay.
But because you've removed that radial digit, you've stripped away the radial support for the thumb you're keeping. The remaining thumb now lacks a radial collateral ligament.
Right. Going back to our guy wire analogy, if you just throw away the radial bone and its ligaments, the remaining thumb is going to buckle every time the child tries to pinch something.
Yeah.
But how do you reconstruct a collateral ligament if you just amputated and discarded the bone it was attached to?
This is where surgical elegance comes in. You don't discard the whole thing. You dissect and harvest a periosteal sleeve from the amputated radial digit.
The periosteum being the tough, fibrous outer layer of the bone.
Exactly. You peel that tough biological scaffolding off the bone you're about to throw away. That periosteal sleeve provides you with strong, robust, vascularized tissue. You drape that sleeve over the joint of the retained thumb to physically rebuild a new radial collateral ligament.
You are literally harvesting the architectural scaffolding from the amputated bone to reinforce the survivor. That is incredible.
It really is. And once the ligament is rebuilt, the intrinsic muscles, like the abductor pollicis brevis, are reattached in a similar tensioned fashion.
What about the joint surface itself?
If there are extra widened articular cartilage facets on the joint surface causing the thumb to deviate, those are carefully shaved down to improve the angular alignment. Finally, because you've just rebuilt the entire joint capsule, the whole construct is pinned and protected with the transarticular K-wire for about 4 weeks while the soft tissues heal.
And what about the deeper duplications, types V and 6, where the metacarpals are involved?
The core principles remain identical. However, because the duplication extends deeply into the palm, you face much more complex intrinsic muscle reconstructions.
Makes sense.
Furthermore, the presence of extra metacarpal bones often crowds the hand, so you frequently have to perform a surgical release to address narrowing of the first web space between the thumb and the index finger.
Okay, let me challenge you on the simpler distal duplications.
Bring it on.
What if we are looking at symmetric types I and II? You have two perfectly equal but very undersized halves right at the tip of the thumb. You can't just amputate one and reconstruct the other, because throwing away a perfectly good half leaves you with a pencil-thin, functionally useless thumb.
You are absolutely right. In the scenario of perfectly symmetric hypoplastic duplicates, you cannot afford to throw anything away. You have to combine parts of both.
Okay.
Historically, the classic operation taught for this is the Bilholt-Cloquet procedure.
Oh yeah, every resident has seen the Bilholt-Cloquet procedure show up on a practice test. Walk us through the mechanics.
The Bilholt-Cloquet involves taking a scalpel and removing the adjacent inner halves of each duplicated thumb. You then take the two remaining outer segments, bring them together in the midline, and secure them with sutures or a K-wire.
So you're essentially splitting both thumbs down the middle and gluing the two outside halves together to make one normal-sized thumb.
That is the idea, yes.
But you specifically use the word historically. Why is modern hand surgery moving away from the Bilholt-Cloquet?
We're moving away from it because it reliably produces highly testable, severe complications.
Like what?
When you combine two distinct halves like that, you almost always get a central ridge or a severe nail deformity. You risk epiphysiodesis, which is the premature tethering and fusion of the growth plate, meaning the thumb stops growing.
And let's think about the joint mechanics. You are taking a complex, smoothly gliding joint surface, cutting it straight down the middle with a saw, and trying to puzzle piece it to another half joint. I mean, it's like trying to cut a door hinge in half and glue it to a completely different half hinge. They are never going to swing smoothly together.
That is the perfect analogy. The result is profound joint stiffness. Because of that stiffness and the growth plate risks, modern modifications heavily favor unequal sharing.
What does unequal sharing look like?
Instead of splitting the nail perfectly down the middle, a surgeon might excise the bone from one side, but take the entire pristine nail bed from the amputated duplicate to cover the reconstruction.
Oh, clever.
Right. Or, to avoid that cut hinge problem, they will perform a bone resection that preserves the entire physis and the complete uninjured joint surface from just one side. You preserve the complex gliding surfaces rather than trying to puzzle piece them together.
That makes profound mechanical sense. Preserve the native hinge. Let's shift away from duplications and talk about anomalies of the phalanges themselves.
Okay.
We mentioned Wassell-Tyke 7th earlier, the triphalangeal thumb. This is an autosomal dominant trait where the thumb has an extra third bone, making it look and bend like a regular finger. How do we manage that extra middle phalanx?
The surgical algorithm depends entirely on the geometric shape of that extra bone.
Shape matters.
Yes. If the middle phalanx is triangular, which we call a delta phalanx, it forces the thumb to deviate at a sharp angle. In that case, the delta phalanx is simply excised, followed by a soft tissue reconstruction of the ligaments.
And if the extra bone is not triangular?
If the extra bone is rectangular, whether it's short or normal length, it doesn't necessarily cause an angular deviation, but it makes the thumb abnormally long and unstable.
So you don't cut it out?
No, you do not excise it. The treatment shifts to chondrodesis, which is surgically fusing the cartilage and bone of the least mobile joint in that thumb ray to restore stability.
Got it. A triangular delta phalanx causes deviation, so you excise it. A rectangular phalanx causes instability, so you fuse it.
Exactly.
All right. We are going to complete this revision session by returning to the scenario I posed at the very beginning. The most extreme upper limb duplication imaginable.
Ah, yes.
A statistical unicorn with only around 60 quoted cases in the last 300 years of medical literature. Walk us through the anatomy and the surgical game plan for ulnar demilia, commonly known as the mirror hand.
The mirror hand is a breathtaking embryological anomaly. It involves a symmetrical duplication of the limb right down the midline. The clinical anatomy is striking. You have a central digit and then 3 fingers on either side of it perfectly mirroring each other.
Right.
Those fingers represent the middle, ring, and little fingers.
Which means you are looking at a hand with at least 7 fingers, but absolutely 0 thumbs.
Exactly. 7 fingers, no thumb. But the skeletal anomaly extends far up the arm. The forearm contains 2 completely formed ulnae and absolutely no radius.
2 ulnae. And because the radius is the bone that allows the forearm to rotate, to pronate and supinate, what does that mean for the joint mechanics?
It means forearm rotation is severely reduced or entirely absent.
Wow.
Furthermore, those 2 ulnae support a duplicated ulnar carpus, so the wrist bones are doubled. Because of this heavily crowded, abnormal structural setup at both the wrist and the elbow is usually profoundly stiff.
I can imagine.
And honestly, the surgical anatomy is incredibly variable, and no 2 mirror hands are exactly alike.
So, as the reconstructive surgeon, how on earth do you approach an arm with a stiff elbow, 2 ulnae, no radius, 7 fingers, and no thumb? Give us the staged surgical wrap-up here.
It's a massive, multi-stage undertaking, rarely performed even by seasoned congenital hand specialists. But for the exams, you need to know the core functional principles. First, you must address the proximal joints.
The elbow.
Right. That means aggressive passive stretching, therapy, and surgical release to mobilize that profoundly stiff elbow. Second, because the hand has no thumb, it has no web space. You have to surgically fabricate a deep first web space.
And the final, most crucial step.
Third, you perform a pellicization. You take one of those redundant lateral digits, carefully isolate its nerves, vessels, and tendons, and surgically reposition and rotate it to function as a thumb.
And the rest.
Simultaneously, you amputate the other extra digits to reduce the total number of fingers to a functional, typical 4-finger hand.
Incredible. You're taking a digit that is structurally built to be a finger, rotating it, and rewiring its biomechanics to act as a thumb.
It's one of the most remarkable things we do.
All right, let's briefly recap the high-yield milestones we've covered today. We broke down the demographic traps of post-axial ulnar polydactyly. We explored the entangled biological highway of central synpolydactyly. We unzipped the Wassel classification for radial thumbs highlighting type 4 as the 43% majority.
Very important.
Yes, and we discussed the biomechanics of preserving the joint hinge over the bilho-cloquet, and we finished with the complex reconstructive steps for the mirror hand.
If you understand the underlying mechanics and the why behind those algorithms, you will be in an excellent shape for the exams.
A quick reminder to grab that premium subscription so you can join us for the clinical cases and journal club deep dives. We also have a direct request for you. Wherever you are listening right now, scroll down and leave a comment or a question about today's material. We want to know exactly what concepts you are struggling with in your revision.
Yeah, please do. It allows us to tailor these sessions to exactly what you need to pass.
To wrap up, I want to leave you with a final provocative thought to mull over for your exams, building off that incredible mirror hand pellicization.
Okay.
We know that surgery happens around 1 year of age to beat the brain's motor mapping. But in a patient born with absolutely no radial anatomy and no native thumb, the brain has never possessed a physiological blueprint for what a thumb even is. How does the sensory and motor cortex suddenly adapt and map a brand new pinch reflex, using a finger that has always been a finger, now suddenly acting as a thumb? Think about the sheer scale of that neuroplasticity. Until next time, keep studying.